Hi, welcome to this episode of the Voices Heard Lives Empowered mini-series from POhWER. In today's episode, we speak to Dan Anderson, who works as a regional manager for POhWER. Dan has worked as an advocate for many years, and during this episode, he offered his thoughts on how the current coronavirus pandemic has affected advocacy and the Mental Capacity Act in particular. We talk about DNARs, COVID-19 testing, and whether the coronavirus has exposed problems that were already there when it comes to applying the Mental Capacity Act. We hope you enjoy this episode. So as a manager of a team of advocates, what challenges do you think the COVID-19 lockdown's thrown up in terms of upholding the Mental Capacity Act?
Well, I think it's presented quite a lot of unique challenges, principally because the way the MCA has been set up was never designed to deal with the circumstances that we find ourselves in. I think there's so many unique circumstances that have arisen that have required people to think of solutions on the fly, and what we're seeing is a real inconsistency in how the MCA is being applied. I mean, and I would add to that the fact that the application of the MCA, particularly in the health sector, wasn't particularly great to start with, and that's not meant as any sort of criticism of our colleagues in health, but we undertook a project a few years back working alongside NHS trusts in a particular part of the country to help them with their application of the MCA, and we found that compared to, example, to social care, the application of the MCA in health settings is not great, and the level of understanding varies wildly across the sector. So it was something that was already struggling to be applied properly, and then a whole new set of circumstances have arisen, and that's made things much more difficult to apply. So I mean, I think, for example, the testing for COVID throws up a particular example of how it's very difficult for the MCA to be applied properly, because the idea of health decisions being required to be made by care home managers or staff within care homes is something that they've never been expected to do before, and it's just asking them to muddle through it without particularly any new guidance that's from government coming out to reflect that, because I think what's happening is people are trying to apply the existing legislation to new circumstances, and it doesn't quite fit, and what you'll see there is people applying it in very different ways with very different outcomes.
Definitely. I think that's a really good summary of the situation, actually. I mean, my sort of experience in practice as an advocate is that, the awareness of the Mental Capacity Act in certain professionals is not always there. And I don't think that's always their fault. I think sometimes, especially if it's somebody who's perhaps been working in that field for a long time, 20 years plus, they might not have had that training and that exposure to when the Mental Capacity Act first came in.
And I think that's absolutely right. I mean, when we did this project, one of the recommendations that we gave afterwards was that the training around the MCA needs to be incorporated when people are gaining their qualifications, because at the moment it's a bolt-on. It's something people are given, a half-day session on at some point every couple of years, and it's not something that is taught as being really, really important when you're, for clinicians, for example, when you're going through all those years of university and being a junior doctor and all that stuff, it should really be being embedded at that point so that it's understood how relevant it is to all the processes that you undertake. But instead, it's not. I mean, dentistry is a really good example of that, because you don't really get an awful lot of training for dentists, and all of a sudden they might be given a patient with learning disability and told, you need to perform a capacity assessment. You now need to treat someone who has issues around, who's not going to be able to give consent for you to put your hands in and around their mouth. And I think it's unfair in a lot of ways to expect a professional who, didn't in their career specifically choose to work with people with learning disabilities to suddenly have all that knowledge and understanding of how to work appropriately with people in those circumstances. There seems to be an expectation that you'll just muddle through when you find yourself in that circumstance. You'll go away and you'll read the legislation and figure out what you've got to do. And I think that's an unrealistic expectation. Just to give a sort of anecdotal example as well, we spoke to a nurse about the Mental Capacity Act. We said the MCA, and she asked if that was something to do with terrorism. And the reason she said that is because her training around the MCA had been 18 months before, and it had been on the same day that she'd been given the prevent training that they're given to deal with potential terrorist threats, and the two things have gotten muddled up in her mind. That's, tells you how little credence is really given to it. And again, I completely understand it. The NHS is overburdened. The idea that just another thing that you've got to factor into your everyday working, it's a really big lot. It's a lot of information to try and understand, and you're given a half-day session. So the fact that the application of it is wildly different is not really surprising. Not something that you can really blame the people trying to apply it for, but it's just something that needs to change fundamentally in how people are taught how to apply this stuff.
Yeah, absolutely. And then obviously in light of the COVID-19 situation at the moment, the Mental Capacity Act hasn't changed at all, has it, in terms of the legislation?
No, it hasn't. I mean, there are brief mention. I mean, when the Coronavirus Act was passed, there was some specific guidance that the MCA would not change. And I think that was important because the idea then was trying to remind people this does not give you the liberty to go and start trying to do things differently. You can't change how deprivation of liberty safeguards are applied. You can't change how you do decision-making processes for medical treatment, all that sort of stuff. And that's fine. That was a good point to make, to say that this doesn't negate the need for it. But what was lacking was then advice for saying, well, how do you now make this decision in this new world that we're dealing with, now that you're going to have to make best interest decisions for people at a much higher rate than you may have done before. During the peak of the crisis, when you had triage decisions were having to be made in hospitals at a rate that's far higher than you would normally encounter, I think it was probably important at that point to really give some good guidance to people about how to apply the MCA in these circumstances. And I think that's what's been lacking, is just this idea of you can't change the legislation in terms of you can't get around it, but there wasn't that advice of how do you now apply it in a circumstance where you're expected to be making these decisions at a much greater rate.
Yeah, and I think another difficulty is, I mean, I can't speak for other advocacy organisations, but with us working from home at the moment, which is perfectly obviously understandable in the context, but
yeah,
we are normally the kind of guardians of ensuring that people's rights are upheld.
I had a conversation with the MCA lead of a trust, when the crisis was just really picking up speed. And one of the discussions was, could we increase the access to the IMCA service because of the anticipated increase in serious medical treatment referrals that we might have? Because, they were expecting we'll have lots of patients coming in. We may need to make triage decisions about who gets treated and who doesn't. We're going to have a lot of rush discharge, all this sort of stuff. So can we have greater access to the service? And we agreed to put that in place. But actually our number of serious medical treatment referrals didn't go up at all. In fact, for a while it dropped. And that's been seen, I cover a region across, the whole central and east of the country, and across all the teams that I cover, the number of serious medical treatment referrals did not really increase during the crisis. Now, we know that there were hundreds more people going to hospital who were seriously unwell than there had been before, and yet the number of referrals to us did not increase. So that idea that the MCA shouldn't change during the crisis and all the proper processes should still be followed, well, that simply wasn't happening because, we know it wasn't really happening beforehand, but we don't know how many decisions were made that should have had an IMCA that didn't, because we don't know what we don't know effectively. But what we do know is they were happening and we weren't being consulted at the rate that we should be. Now, again, I understand that sometimes those things may be due to expediency and the need to do things quickly, but I think sometimes that gets used as an excuse to not follow our processes properly as it should be. I don't know if that's the same experience you had working under the MCA, but did you see a greater increase in SMTs during the height of the crisis?
No. I mean, I was expecting the same, to be honest. And I had one case that was a serious medical treatment to do with COVID-19, and I was expecting that to be the first of many. And like you say, we haven't seen an increase, and in fact across all of our services, apart from mental health advocacy, we saw a dip in referrals, which, like you say, I guess it's all hands to the deck to a point, isn't it? And people have been moving around teams and redeployed to be more effective in dealing with COVID-19. But I think, like you say, it is, it's a statistic we don't have, but I imagine it will be quite shocking to see the amount of people that have gone through without representation.
Yeah, no, it underlies the problem, because if the use of the IMCA service, if the application of the MCA had been well grounded and working properly before the crisis started, I expect we would have seen those number of referrals. But what I expect is that because those referrals weren't being made, pre-COVID, when the crisis hit, that problem was just exaggerated. The fact that the referrals weren't being made. I mean, the DNAR issue has been something we've been talking about for a long time pre-COVID, which is, if you think of the criteria there, that every time a person who lacks capacity and has no appropriate family or friends requires a do not attempt resuscitation order, there should be a referral for an IMCA. I mean, there are some circumstances where it may not be necessary, but overwhelmingly the majority would require one. Now, from having done, in my past experience as an advocate, having done paid rep work for people deprived of their liberty, if you go to a care home with a lot of people with dementia, things like that, the likelihood is the majority of people will have DNARs. Now, if every one of those referrals that should come in did come in, we would be overwhelmed by them. But in fact, we get a handful a month, if that. Sometimes, I've seen whole 3-month periods, whole quarters where we've seen one or no referrals for that at all, which highlights that, in that particular circumstance, it just, the infrastructure for that was not in place before the crisis. So it's no real surprise that when things got worse and people were under more pressure, that didn't improve the way it should have done. And I think it's an opportunity, if nothing else at the moment, to really cast a light on that, because we know that blanket DNARs were put in place. We know that there were examples of really poor practice around do not attempt resuscitation orders and the use of other advanced care planning, things like the respect process. There's all kinds of blanket decisions that are being made there. And, these are the sorts of things that, as you rightly said, an IMCA would pick up on if they were being consulted with, as they should be. But the fact is they weren't before the crisis, and they certainly haven't been during the crisis.
Definitely. And I think that leads on to the chilling issue. Since the COVID-19, I'm sure you're aware of these kind of stories of blanket DNRs being placed on care homes as a result of COVID-19, really, without regard to an individual and their circumstances.
I think chilling is a really good way of describing it. I think the idea has been, again, it seems to be a focus on expediency and doing things quickly, as opposed to following the proper processes. And again, as you said at the start, it was very clear in the Coronavirus Act that there should not be any change to the MCA. Just because of this circumstance doesn't mean that corners can be cut. These decisions still are hugely important, and they, have a huge impact on the lives of many, many people. So the idea that these things can be skipped over just because of the crisis was never allowed by government. I think it is very worrying.
Definitely. If we could talk a little bit about the COVID-19 testing. I've not had any kind of personal experience of having to do an SMT around this. So I guess the first question would be what does the test involve, and does it constitute a serious medical treatment decision?
Well, that's a really good question. I mean, looking at it from the perspective of an IMCA, you could argue that no, it doesn't constitute a serious medical treatment, because a serious medical treatment referral must come from a clinician. Now, as I said at the start, one of the issues here is that the testing is expected to be undertaken by care home staff, and because of that, there is no requirement to involve the clinician. So if a referral was to come to the IMCA service, then it would be from the care home staff, which, if we're getting into the technicalities of it, means that it isn't technically, it's a best interest decision, but it's not strictly a serious medical treatment issue, which to me seems an issue of semantics, really, because obviously it is a medically motivated decision, so therefore really it should involve someone who is medically trained. Now, obviously, because of the scale of the testing, that isn't going to be possible. It's not going to be possible to get a GP or a doctor to come in or to oversee all testing of all individuals. It's likely to be just impossible. But that does highlight, as I said earlier on, one of the areas in which the current legislative framework doesn't account for this circumstance. So I think the issue there is that it technically could be a medical treatment referral, whether it's serious or not. And this has always been something that's open to interpretation within the MCA. It would really depend on the individual circumstances, because if you're going to have to swab someone, for example, then, if you've got someone with capacity, you ask them. If they say yes, it's not a problem. For a lot of people who lack capacity or are unable to comprehend why this is necessary, why someone's putting something in their mouth, it may still, for a lot of people, not be a particularly stressful or unpleasant experience. But there are going to be some individuals who are not going to respond well to having someone trying to, swab the inside of their mouth, for example. Now, we know that there are a lot of clients we've had in the past who, going back to this idea of dentistry, for example, require sedation in order just to have, a dental checkup, because it's not going to be possible, given their personal circumstances, for them to understand or be able to sit in a dentist chair, hold their mouth open while the stranger puts things in their mouth. It's just not something that some people are going to be able to cope with. Now, similarly, in these circumstances, if you're expecting to apply tests like these for people who are in those circumstances, how are you going to go about doing those tests? Now, for some people, it may be necessary that restraint is going to be required, or possibly sedation or something similar. I should imagine these cases will be hopefully few and far between, but they will be out there. And in those circumstances, how do you approach that? And I think it's really pertinent to remember at this point that it's not like you test someone once and then that's it, you never need to test them again. If you're going to be testing someone who's particularly vulnerable in a care home where, as we tragically know, the illness is able to spread very easily because it's such a closed shop. So I would imagine you might test someone today, and then if someone develops symptoms or if you have any concerns, you might need to test them again next week. You might need to test them every month or every couple of weeks or even more frequently. It's not clear to me yet how often it will be, but it's likely to be a process that requires repetition. Now, if you're going to have to restrain or sedate someone, and as I say, it's not going to be necessary in most cases, but if it is, if you're repeatedly having to do that to someone, or you're repeatedly, even if you don't require that, but the process just causes them distress, even if they're willing to do it, and they find it very, very unpleasant, if you're going to have to repeat that over a period of time, how does that make you feel about where you live? How does that make you feel about the staff who you work with, who it's important for you to trust and have a good bond with, who are required to repeatedly undertake a process that you don't understand and may find very difficult? And what I think there is, how does the existing guidance support people who have never been asked to make a decision like this before, a best interest decision for someone like this before? How do you guide them to do a decision like this? And can an IMCA even be involved? Now, I would argue, because of the fact that it does have medical implications and, the seriousness of this, whether this constitutes a serious medical treatment referral or not, I think the serious nature, you can deal with quite easily, because, COVID-19, does kill people. And if you are someone who is in a high risk group and you're in a care setting, then your risk factors are notably increased. So I think the idea of knowing whether you are unwell, whether you could spread it to other residents, whether it could have an impact on you and the people around you, I think it is important to know whether people have symptoms or not. So therefore, I think whether it's serious or not isn't really up for a massive amount of debate. I suppose there could be circumstances where a person is isolated within a care home to such an extent that they're not going to come in contact with anyone else, and then perhaps that risk goes away. But I can't envision a circumstance where that happens. And even if it is happening, that would raise a whole other set of questions about why is that person being isolated and having no contact with anyone else. So I think the notion of it being a serious issue is evident. I think I would certainly, if the care home was to come to us and make that referral, even though the current legislation doesn't really give guidance on whether it should be involved or not properly there, I would certainly take on that referral and expect one of our advocates to undertake it, because the requirement to represent that person really is there. And I'd want, particularly given the fact that the best interest decision maker in this process is someone who would not have been expected to make a decision like this before and could really benefit from that guidance. So I think it's really important that the IMCAs can be involved when these circumstances do arise. But again, part of the issue of the people being asked to make these best interest decisions not having a history with them is, how will they know to refer to an IMCA? The guidance isn't clear. They wouldn't have had to do it before. So we're expecting them to suddenly, via osmosis, to have knowledge of a process that isn't well laid out and they've never known about before. And I think that means the likelihood is a lot of times people are not going to get referred for this sort of thing, which is really worrying.
And I guess there would be cases that if a person was properly represented, it could be challenged in the Court of Protection, as any other SMT would be.
Yes. So the best guidance I've seen around this comes from Essex Chambers, and they do make it clear that in those cases where a person's really unhappy about the testing, or if there's real concerns about how it can be applied, that there should be an application made to the Court of Protection. But again, I think the concern there is that the people who would need to make that application, who are being asked to now undertake this process, are they going to be familiar with that requirement? Do they know how to make the application? Do they know that that's an option? I mean, I know that I had to really go out of my way to research to find information about that sort of thing. And I think there's just this idea that people, it's out there on the internet, you can Google it. So that effectively means you now know what you're doing. And I think it's not enough. It means that in these circumstances, we're hoping and putting faith in the idea that the people who are required to make those applications will do so. But I don't know that they will. And that's, again, not a criticism of the care home staff in these circumstances. I think they are being required to undertake something which is a huge task and a really difficult one, and one that they've not been specifically trained for or expected to do before, and expected to do it well. And I think that's unrealistic and unfair. I think what would be necessary throughout all this, throughout the testing process, is guidance from central government coming out to all people required to administer these tests, saying these are the processes, this is the circumstances when an IMCA will be necessary, this is the circumstance where an application to the Court of Protection will be necessary, this is what you can and cannot do. I think asking people to just muddle through it is creating a circumstance where things have a much greater chance of going wrong. That's how I see it at the moment.
Yeah, no, I'd be inclined to agree, to be honest, especially given that as advocates, we obviously have a professional interest and a professional curiosity, and we have that knowledge to look at where these issues might come up and where things might be going wrong. But for a lot of family members or kind of close friends who are, would normally be acting in that role, I would bet that 99% of people wouldn't know where to go, where to start if it came to raising an objection about COVID-19 testing.
I think it's really asking people who, as I say, who have no real knowledge of these processes to suddenly become experts on it overnight while managing a care home that might be dealing with, very unwell people, who ordinarily would have very challenging circumstances, but now have this crisis on top of it. So expecting to become an MCA expert in the midst of all this is, I think, a little unfair.
Yeah.
And the only way to really get around that is to try and provide, really clear guidance that says, there is the fact that under the MCA, you need to treat a person individually. You need to apply things as best you can to the individual circumstances. So having, flow charts or something that says, do this, can be counterproductive because it stops people from thinking and puts too much trust in a process. But at the same time, not having any really clear guidance apart from the existing frameworks and legislations, I think is expecting people to pick up too much without guidance.
So we've talked quite a bit about DNARs and about the COVID-19 testing. Are there any other areas of the MCA where your advocates have run into issues, or where you feel the MCA is not being applied properly, either because of COVID or because of a lack of scrutiny from advocates and from outside agencies?
I think some of the areas of real concern for us at the moment, and again, it's kind of the things that we don't know what we don't know, are the accelerated rate of discharge from hospitals has thrown up some issues of concern, because ordinarily if you have a circumstance where someone's been admitted to hospital, perhaps someone with dementia who no longer is safe to return home and needs to be considered for perhaps a move into care, that would be something where a change of accommodation referral would be made for an IMCA if they meet the criteria of lacking capacity and having no appropriate family or friends. And then the person would ordinarily not be discharged until a proper, suitable placement had been found. Now, discharges had to be accelerated at the moment. And again, I'm not criticising that. It's absolutely necessary. And, if people have had to be moved out, one of the things we've been speaking to different local authorities about is some of those people perhaps have had to be moved out into temporary placements whilst, a more suitable long-term placement can be found. One of the things I think we'll have to see over time is those people who've been sort of put somewhere in a bit of a rush to discharge them from hospital, whether there will be proper reviews of those placements in future to see if they are the best place for a person to remain long term, and if it's identified that it's not, how quickly will they be assessed for where they can go to have a more permanent placement. Now, again, it's not something where I'm saying we're seeing terrible practice. I'm not criticising the speed of discharges, because I think they absolutely are necessary when, particularly during the height of all this, when bed space in hospital was absolutely essential. But I think what we'll really need to see is how this is applied in the long term. So some of those people who've been moved urgently, do they get picked up and properly assessed to where they should go long term, or do some of those people get forgotten about? And are IMCAs involved when they should be, when the further discussions happen to where they should go long term? Because we wouldn't have been involved in the discussion for the urgent discharge, because that would have slowed down the process. And again, that's fair, but we should be involved for qualifying clients when the decisions about a long-term placement are made. I mean, that would be the first thing that I think was my other concern that came up. The second thing would be about the application of the restrictions under the deprivation of liberty safeguards during the crisis, because obviously you have a lot of people who would ordinarily access day services, who would go out and about to see family, all that sort of thing. And a lot of those things haven't been possible. So there have been required to be additional restrictions where conditions that may be set under the deprivation aren't being met, for good reason. We also have heard anecdotal examples of people in care homes who've have to be restricted to their bedrooms for extended period to prevent cross-contamination or the risk of infection when there may be someone else in the home who has symptoms. And again, I'm not saying that's inherently wrong, but what I'm not convinced about is that in some of those circumstances, whether the local DOLS teams have been contacted to inform them we're having to restrict this person's liberty more than we have been authorised to do under the deprivation order because of the current circumstances. And again, I think it's been the expectation that care home staff are having to just muddle through in a completely unique circumstance and do their best. And again, it would have been useful for guidance for care homes to say, if you are having to place increased restrictions on your residents, and the same in hospitals, because of the risk of infection or to protect people from possible infection, then this is how you manage it, this is how you record it, this is who you inform. Because, again, I don't think any of these things will have been motivated by anything other than the best interests of the individuals concerned. But I think how it's recorded, how it's discussed, and how it's agreed is probably not very uniform. And I think, again, what it seems to me is just a lot of really important decisions are being placed on the shoulders of people who shouldn't be necessarily expected to make those decisions and potentially suffer the consequences of the decisions if they're made poorly or incorrectly. So again, I think some guidance around how to enact the deprivation of liberty safeguards in a lockdown society probably would be useful. It probably would have been more useful a little while before, but as we're moving away from that part of the crisis now, but with the possibility of a second wave and all those sorts of things, I think it's something that really needs to be discussed, particularly as I think even as the rest of the country feels like it's starting to move out of lockdown. I suspect if you're in care homes and hospitals, that process will be much slower and you will remain more secured for a lot longer.
Definitely. I mean, yeah, we're talking potentially 6 months, probably even longer, until care homes feel any different to how they are right now, aren't we?
Yeah, and as you said before, it's the sort of thing that we would pick up on through our PR visits, through the other bits and pieces we do as IMCAs, but at the moment we don't have the level of access that we would usually do, and we're reliant on what information we can glean from our clients when we speak to them on the phone or by other communication methods, or what we're told by the staff. And obviously, if there is some bad practice going on, we may well not be able to spot it in the way that we usually would. So, the risks have increased and the safeguards, or the ability to enact the safeguards, have gone down. And I think that just creates a circumstance where the possibility of things going awry is much higher than it usually would be.
Yeah, obviously working from home has been a massive challenge across the nation, whatever people do. But in terms of advocacy, have you been kind of pleasantly surprised with what advocates have been able to achieve working remotely, or do you think it's been a massive kind of insurmountable problem which has reduced our ability to advocate effectively?
I think it's been it's kind of an on the fence answer, but I think it's been a very mixed bag. I've been really pleasantly surprised by the way it's worked in some circumstances. I mean, I think it's really helped our staff to gain a much better understanding of the use of technology. We found that some of the younger clients we work with have really preferred, this remote communication, because I suppose that's a generational thing of, younger people are used to communicating more through technology than perhaps the older generation are. And I think in some circumstances it's really worked. And we found that some hospitals, care homes, places like that have really helped us by being very, very supportive of providing equipment for their service users to use and ways for us to access them. So some parts have been great. There are some parts where, as I've said just now with the RPR service, for example, where there just is no substitute for face-to-face work. And some of those parts we've been able to, I've been hugely impressed by, the colleagues I work with and their ability to make the best of this. But I think when you are working with clients who have severe communication challenges, I think there is no substitute to that face-to-face work. So that's one of those things that I'm really hoping to see back to normal as soon as is humanly possible. So, as I say, I think it's a mixed bag. I think we've been able to do some really impressive stuff and really make the best of the circumstances, better than I ever would have anticipated, if I'm honest. But I do think there are some aspects of the work where there really will be no substitute for that face-to-face.
Yeah, no, I'd completely agree with every point you make there, Dan, to be honest. I think by the nature of people that get into advocacy or get into health and social care generally, they like human contact, they like helping other human beings. And so to have to adapt to not being in the presence of them and doing everything over the phone or the computer, it has been a massive challenge. Like you say, I've had some clients, for example, with autism, who they probably feel more comfortable speaking over the phone than they would do in person, because it eliminates that worry about kind of social cues and things like that. So there are examples of where it works and where it might even be adopted long term. But I would agree with you that there are a great many examples of situations where we just aren't able to scrutinise or have that relationship with a client in the same way.
I mean, there is, necessity being the mother of invention. I've seen some really good examples of creative solutions to problems that people have come up with. I mean, I was talking to an advocate the other day, and it's one of the first face-to-face visits we've been able to go back and do with a client. And the issue is that the advocate wearing a mask and having to be socially distant, the client, the relationship they had built up in the past didn't seem to be there in the same way, because the client couldn't see the advocate's half of their face. They've got a visor and a mask, so you can only see their eyes, and they can't really, can't see the lips moved, so you lose a lot of the verbal communication from that. And what the advocate did was take in a big laminated photograph of herself that she wore around her neck to help the client identify who it was they were speaking to, and that had a hugely positive impact. The client was able to remember who she was and remember the relationship that they'd had, and that helped a massive amount. It's the sort of thing we think that's a very creative solution to a problem we never would have encountered before. And I think we're seeing lots of little bits and pieces like that where people are just coming up with very novel solutions to problems that we never thought we'd have to solve. And I think that really helps a lot of people rise to the fore in terms of coming up with good creative solutions.
That's brilliant. I think that's quite a heartwarming example, really. We've seen the same, haven't we, on kind of ICUs and things like that. These doctors with, full PPE having pictures themselves on their, like on the badge or something like that, or stuck to their uniform. So yeah, no, that's really good. Is there anything else that you want to kind of mention and get in there relating to kind of the Mental Capacity Act?
What this crisis has done is it's really thrown into sharp relief the failings in the application of the MCA that were already in place. And I think things like DNARs, we've been talking about that for a very long time and have gained very little traction in terms of any change for that. The only hope is that some good things can come out of such a terrible set of circumstances, that perhaps now the rest of the country maybe is paying a bit more attention to. For a period of time there, it felt like DNARs were something that were in the wider public consciousness in a way they hadn't been before. And my only hope is that, as a result of all this, that perhaps some of that learning can be taken forward, and we can actually see that, even if we are able to get back to something approaching normality in the near future, that we don't go back to the same mistakes that existed before.
Thanks for listening to this episode of the Voices Heard, Lives Empowered mini-series by POhWER. If you'd like to make a referral to POhWER, you can fill out the online form at www.pohwer.net. That's POhWER.net. You can also call our help hub on 0300 456 2370. Thanks for listening.